So the topic today, as you know, is lymph node surgery for breast cancer. This is a confusing topic, and if you come out of my talk saying, what exactly did she say? Or if you've been through breast cancer and it's not clear to you how these apply to you, that actually is the state of how we manage the lymph nodes. It is an area of constant change. The recommendations change. If I give this same talk next year, there will be different information as more and more research comes out. So really, as I talk about this topic, it's really going to need to be a journey through history to explain where we've been and then say where our current state is and then where we might be going. So prior to the late 1800s, breast cancer was fatal. Sometimes surgery was done, but if the patient didn't die of breast cancer, oftentimes they died from the surgery itself. It was before anesthesia was available. Ideas of infection control didn't exist. There was no medical therapy for breast cancer, and there was no radiation. This all changed in 1882 with what's called the Halsted radical mastectomy. So Halsted was a surgeon at Johns Hopkins, and he proposed this very extensive surgery. It involved removing the entire breast, removing the pectoralis major muscle, which is the major chest wall muscle, and it's the muscle behind it, and really cleaning of all lymph nodes underneath the arm and over the clavicle. They would then cover this area with a skin graft. This was a revolutionary procedure. He published information concerning his first 50 patients, and he was very proud to say that no one died during surgery. Local recurrence rate over the next year was about 6%, and 3-year survival of his patients was 45%. These obviously are very shocking and not good numbers. However, at the time, it was better than what they had been seeing. So if you thought of, so someone has breast cancer, the only modality to treat it was surgery with the radical mastectomy. And over the next 70 years, the belief was really more surgery was better. And this was the belief for 70 years. And actually, they extended it to the super radical mastectomy, removing lymph nodes in the neck. The data didn't say survival was really any better, but this was the standard of care. And this is an example of what the radical mastectomy looked like. So you can see the skin graft is right on the chest wall. It's very disfiguring, limited mobility of the arm. And sometimes I still see patients who've had a radical mastectomy or who are seeing me for a new problem. So this surgery, even as the research that I'm about to discuss came out, surgeons were very reluctant to give it up, and this carried on into the 1980s. But as time progressed into the 1950s and 60s, we began to see that there were other ways to treat breast cancer. And so surgery was part of it, but medication could be a part of it, radiation could be a part of it, and together develop a treatment plan. And really the father of this idea was Bernard Fisher, who's pictured here. And really he thought that maybe less could be more in terms of breast cancer is not the orderly disease that William Halsted thought it was, meaning it doesn't always go breast to lymph nodes and then everywhere else, but that the cells can escape. And then therefore, at the time of diagnosis, could it be actually really considered a systemic disease? And really, this brought to mind that breast cancer treatment should be what we call multidisciplinary or multimodality, that we need to always rely on all the ways we have to treat breast cancer, not just the breast, but the whole body. And by the late 1960s, research began to disprove that the radical mastectomy was any better than a total mastectomy, meaning removing the breast, leaving the muscle, leaving the skin. Actually, this was really revolutionary. Surgeons were not happy with this research. Actually, Bernard Fisher received death threats for having proposed this. But through very careful randomized controlled trials, he was able to document that this really was true. And so through the studies that he started with the National Surgical and Adjuvant Breast Project, he was able to show that breast conservation, maybe doing a lumpectomy with radiation, was reasonable. He started to propose that perhaps limiting the lymph nodes you remove would be possible. And he really emphasized the need for medical therapy, whether hormonal-based therapy or chemotherapy. And so today, when I'm seeing a patient with breast cancer, this is what I'm thinking of. So we have breast imaging to rely on. We want to know specifics about the pathology. Do I need to think about genetic testing to see if there's a predisposing factor? Surgery, of course, I'm a surgeon, but also my understanding of the medications that could be recommended and the role of radiation will allow me as a surgeon to develop an optimal treatment plan to discuss with the patient. This next slide is actually a slide that I give to clinicians to try to explain all the different nuances of what I need to be thinking about. But when we think about all those different pieces, what really am I thinking about? So with breast imaging, I want to know how large is the cancer, and do we see any abnormal nodes under the arm with imaging? With pathology, I want to know, is it a ductal or lobular type cancer? I want to know the grade, which is the level of aggressiveness. I want to know, does it use hormones for fuel, and does it have the HER2 growth factor? Because all of those pieces will influence the medical therapy recommendations, which actually can influence the whole treatment plan. I'll assess genetics. With the medication box, you can see, will hormone blocking medication work? Do I need chemotherapy? Do I need to give that Herceptin for the HER2 growth factor? And we do now have an immunotherapy option for certain types of cancers. And then I also need to think about radiation. Does the patient have the type of cancer where radiation would be needed? If it's needed, is it given just to the breast or chest wall? Or is it also given to the lymph nodes? There are actually some patients with medical conditions where we can't give radiation, or they've had radiation before. And so all this comes into play in terms of developing a treatment plan. So here you can see a picture of the breast. And with my pointer here, the breast drains through lymph channels to the lymph nodes underneath the arm. We call this region the axilla, but also lymph nodes go behind, below the clavicle and above the clavicle. But we also need to point out that lymph nodes drain fluid from the arm, and these actually are all very interconnected. And the consequences of being aggressive removing lymph nodes is something called lymphedema. And really, this is the core of the talk today. So what is lymphedema? Lymphedema is a buildup of fluid in the arm. Actually, people can have lymphedema of any of the extremities, arms and legs. It can be due to many factors, but certainly surgery of the lymph nodes can be a cause of that. It is disabling, it is debilitating, and it is disfiguring. From the Social Security Administration estimate, the lifetime cost of caring for one patient with lymphedema is at least $100,000 per year. Costs are as listed here. And actually having lymphedema is a qualification for disability from the Social Security Administration. So this is a very significant problem for patients. There are some risk factors other than surgery that can predispose to lymphedema. Obesity is one. Also, sometimes radiation is given to the lymph nodes, and that can impact that as well. Now, what are symptoms of lymphedema? Obviously, swelling can be one of the symptoms, but actually there are some clues that it's developing even before there is visual swelling. So patients may complain of a sense of heaviness of their hand, their forearm, or the whole arm. They may say that they have a feeling of tingling. Sometimes they can have swelling, but more commonly, they might say, well, my wedding ring isn't fitting quite like it used to. My watch band feels tighter, or just the joints in my hand or my wrist feel tight. And any of those can be a trigger to evaluate for lymphedema. So when we think of, well, what's the risk of lymphedema with removing lymph nodes? If we go back to the radical mastectomy, where we're removing all of the lymph nodes in this picture, the risk was about 50% and oftentimes greater. Through the work of Dr. Fisher, he was able to document that we don't need to be that aggressive, and a procedure called an axillary node dissection was formulated, where really it was the lymph nodes most connected to the breast here, but not underneath the muscle or near the clavicle. And with that, we reduced the risk of node dissection to about 15 to 20%, which are still very high numbers. And so this slide is going to keep popping up as we go through the transitions we've made in lymph nodes so you can see where we're going. So really, what is the issue? I mean, if we could prove that survival rates were better removing all these lymph nodes, that might be nice, but actually the research shows that it doesn't improve survival. But the status of the lymph nodes, whether there's cancer in the lymph nodes or not, can impact decisions regarding other treatments, say medication, chemotherapy, how to give radiation, how much radiation to give. And so really, as we think about how we treat breast cancer, we need to find the balance between optimizing the information gathered with surgery and minimizing the risk of lymphedema. So as we've gone through the last really 30 years, if you want to use one word to describe what we're doing with lymph node surgery, it's the word de-escalation. We're doing less and less and less, and really trying to tailor our recommendations to the specific patient, not have kind of a rubber stamp across the board. And so the first real big change in the last 25 years was a procedure called the sentinel node biopsy. Now, the research on this came out in the late 1990s. Kind of an anecdote, I was in medical school up at the University of Vermont and in the early 1990s, and there was a surgeon there, Dr. David Cragg, who was part of the study that proved that the sentinel node biopsy was safe and appropriate cancer care. And all the other surgeons, they talked to us medical students saying that he was crazy thinking that this would work, and why was he not offering his patients the standard of care? Well, he was proven right, and he was the first author on the paper that really showed that this was the future. And so what is the sentinel node? The sentinel node is the first lymph node the breast drains into. Now, it might not just be one node, it might be 2 or 3 or 4. It's really how your anatomy is. So any patient may have a different number. But we inject dyes into the breast. One's a blue dye, one's a radioactive dye, and we identify whichever lymph nodes have collected both dyes. That's the sentinel node, and that's what we remove. I said we use a radioactive dye. It is minimally radioactive. It's injected in the preoperative holding area. It's gone really within 6 to 12 hours. And this is the probe we use at Baystate, but there are many probes out there that will detect the radioactive lymph node. So as I said, we inject these dyes, and really the reason why we're even doing this again is optimizing care. So if you think of, the chain of lymph nodes that I showed you in the picture, if that sentinel node, that first node is negative, the research showed we've proven that all of the lymph nodes are negative, and we're done. If cancer was in that sentinel node, it'll impact radiation and medication. And at the time this came out, the recommendation was to proceed to that full node dissection. So now we have taken, if you think of 100 women, all women received a node dissection with that 15 to 20% risk of lymphedema. Now we have actually carved away probably 70% of those patients to only have a sentinel node, and the other 30 would have the node dissection because cancer was in their lymph nodes. And if we go back to this slide, we've gone from over 50% to 15 to 20%, and now research on the sentinel node excision looking at lymphedema said approximately 4%, so doing much better. And so this was the status quo for the next 10 to 15 years until the next big change came. And this was a study, a randomized controlled trial called the Z11 trial. And Z11 was just the name of the research that it was given. And this was yet another revolutionary study. And so this looked at patients undergoing lumpectomy who had a tumor really 2 centimeters or less. They were going to get breast radiation, and they had a sentinel node excision. And if they had 1 to 2 positive sentinel nodes, they then got randomized to doing the standard of care, which was the node dissection, or not doing any further surgery. And what the research showed was the survival of these patients was exactly the same, whether they had more surgery or not. The recurrence rate, so cancer coming back in the breast or in the lymph node, was exactly the same, whether they had more lymph nodes removed or not. But the complications, lymphedema, numbness, reduced range of motion of the shoulder, was clearly greater in the node dissection group. So really, this is what we call a non-inferiority study. So we showed that not doing more surgery was not a worse outcome than having more surgery. Now, one of the caveats to the study and the results was that 96% of the patients received some sort of medication, whether chemotherapy or the anti-hormone treatment. So that is clearly a very important part of being able to avoid the node dissection. And so back to this slide, we're now with the sentinel node excision. And then some of those patients did receive radiation to the lymph nodes. Risk of lymphedema is about 5 to 10%, still much better than that 15 to 20%. Now, I threw in here that there are some times where we not only have to do the node dissection and node radiation with a risk of 30 to 40%, and that is clearly, the patients with the most advanced cancers that we need to be that aggressive. But again, we're trending down. So our next big change came in 2016. And what happened were the Choosing Wisely guidelines came out. So a government agency tasked all of the major national societies to come up with 5 things that were quality-based and value-based that they recommended. So it wasn't just cancer. The American Cardiology Association had to come up with the 5 most important things for patients to know about cardiac care. It went across all the specialties. So the Society of Surgical Oncology came out with its 5 things, and it could cover any aspect of cancer. But you see here, number 1 was don't routinely use sentinel node biopsy in clinically node negative women, which means you can't feel any abnormal nodes over the age of 70 with cancers that are fed by hormones and were invasive cancers. Again, this was revolutionary. We had never before considered that we wouldn't need to remove lymph nodes. You could be 90 and we were still removing lymph nodes. This is evidence and research based because there were individual studies that, when all put together, would tell us that that not all patients benefit from lymph node removal. The results of a lymph node removal, if you couldn't feel any abnormal lymph nodes, didn't impact medication recommendations or radiation recommendations. And so we adopted these guidelines. There was a lot of conversation at our team meetings with all the cancer specialists to make sure that we felt comfortable, but really when put together, the data was very compelling. So if we're going to follow this, again, clinically node negative, it couldn't be a high grade or aggressive cancer. It had to be not a large cancer. And the other thing was it had to be hormone receptor positive so that the anti-hormone medication could take effect. And so now we have a group of patients that now we're not removing any lymph nodes. And if we're not removing lymph nodes, we're not going to get upper extremity lymphedema. So now we're doing better. And now we're getting to 0%, which is, of course, where we would really like to be. So we have a more recent big change, and this is something that received FDA approval last year called MagTrace. So MagTrace is a dye. It is iron oxide, but the thing is, it's a dye that will remain in the lymph nodes for about 30 days. And it allows for identification and removal of the sentinel node after the initial breast cancer surgical procedure. So there's a spectrum of cancer, as there is spectrums of so many things. And so there are some patients who are diagnosed before the cancer cells lining the duct, as you see in this picture here, have not broken out through the wall of the duct. That's called in situ type cancer. By definition, if the tumor cells are trapped within the wall of the duct, they can't go to lymph nodes, versus an invasive cancer that's broken out through the wall of the duct can. But there are times where a patient has a needle biopsy with an abnormal mammogram. The needle biopsy shows the in situ cancer, but when we do surgery and give the lab more tissue to look at, we find out they have invasive cancer. That's called upstaging. And so these were patients where we didn't think we needed to remove lymph nodes, and now we need to think about it. So, when we do the standard sentinel node at the time of a breast procedure, we use, as I said, the blue dye and the radioactive dye, but they only stick around for about 24 hours, and we never have lab reports from surgery in that time. So for many of these patients with in situ cancer, it became this, quandary of, what do we do? Do we just do the breast procedure and then figure out what to do with the lymph nodes, or remove a sentinel node at the same time, just in case? And there is a particular group of patients with in situ cancer where this was very important discussion to have. And these were the patients having a mastectomy, either because the area of in situ cancer spanned the breast or a personal choice. And so up until the time that MagTrace was available, 100% of those patients would have a sentinel node removed at the time of mastectomy so that if they were upstage to invasive cancer, we would have checked the lymph node. If they just had a mastectomy, and that's all we did, and the lab report came back and said they had invasive cancer, we can no longer inject the dyes, we cannot identify the sentinel node, and oftentimes we would have to do a node dissection to know what was going on with the lymph nodes. And the way to think of it is about 10 to 15% of patients with in situ cancer get upstaged with surgery. So of 10 patients having a mastectomy for in situ cancer, 8 to 9 of them would have had a sentinel node removed that they did not need to have removed. And that clearly is really not optimal. There is also another group of patients who have the in situ cancer, and it's really in that high upper outer breast tissue near the lymph nodes, that if we do a lumpectomy, we will disturb the lymph nodes and we would not be able to inject the blue dye, any dye afterwards and have it get to the nodes. So with MagTrace, we are able to inject the breast with the MagTrace at the time of the mastectomy. And then we just stop and we do the mastectomy. We wait the 1 to 2 weeks to get a lab report back. And if it says that that there is no invasion, so they just have in situ cancer, we're done. And we've taken out 0 lymph nodes. If we find that they're upstage to invasive cancer, we can now go back, identify the sentinel node, and remove it. And so now we are saving a whole host of patients having any lymph nodes removed. And again, bringing down that risk for those patients down to 0%. So this is really, we're so excited to be able to offer this at Baystate. It is a wonderful change for our patients. So what's next? Where are we going? So right now, the standard of care for patients who are found to have cancer in the lymph nodes at the time of diagnosis, we will give them chemotherapy to try to, wipe out the cancer in the lymph node, and then try to perform that sentinel node excision afterwards. But there are some patients that the lymph nodes stay positive after chemotherapy. And the standard of care right now is to have them undergo a lymph node dissection. A study has been ongoing, and we actually were able to enroll patients in this study called the Alliance 11202 trial. And what this did is randomize patients, if their lymph node remained positive, to either get the node dissection, which is a standard of care, or lymph node radiation. And it's looking at recurrence rates and survival rates. They finished accruing. We're waiting the results. With any cancer trial, it's usually about 5 years before we'll really hear anything. But I am really hoping that we find out that for most patients, the radiation is equivalent, because radiation to the lymph nodes has half the lymphedema risk as the node dissection. So again, this would be a big win for our patients as long as it's safe. So as I said, it's very confusing trying to keep up with what we're doing with lymph nodes. So, my first question when I see a patient and I'm thinking about the lymph nodes is, do we need to even remove lymph nodes? And, the first step of that is what type of cancer, invasive or in situ. So if I identify that I need to remove a lymph node, then can we do a sentinel node excision? Yes, if there's no evidence that there's cancer in any lymph nodes. It would be no. If we know that there's cancer in the lymph nodes, we would refer the patient to receive medical therapy to try to wipe out the cancer so we can avoid the node dissection. The Z11 trial, if there's cancer in the sentinel nodes, can we just use radiation, avoid the node dissection in those patients? And then the final step is, if we know we need to do a node dissection, what can we do to minimize the risk of lymphedema? So the first step of that piece of it is there's now a concept called prehabilitation, which is different than rehabilitation. And this is identifying the patients at high risk for lymphedema. And we get them to our lymphedema therapy team. We get the arm measurements before they've had any surgery or radiation to the lymph node area. They're, taught exercises, massage, and we try to get ahead of the curve. During surgery, we would do what's called reverse lymphatic mapping, where we inject some dye into the skin of the arm. So the dye goes into the lymphatics, draining the arm, and we can stay away from those lymphatics. And finally, there's a new procedure called the lymphatic bypass procedure. And what this is at the time of the node dissection, a microsurgeon will perform a reconnection of lymphatic channels that drain the arm into a vein. And the research is very new procedure. The research from the major centers is showing that this is vastly helpful in reducing the risk of lymphedema. And one of the institutions in Boston actually in their study that came out showed that they had actually reduced the risk of lymphedema to less than 10%. So we are finally able to offer this at Baystate. We have one microsurgeon who does it, so scheduling is a little bit tricky, but this is, will be the way of the future for those patients who need the node dissection. So in summary, fewer patients are faced with lymphedema. We are doing a better job at identifying patients who will benefit from lymph node removal and those who will not. If possible, we don't do it. The indications for removal of the lymph nodes is going to continue to decrease as the other modalities in breast cancer care continue to improve. The sum total is more is definitely not better when it comes to lymph node surgery. And I will not be upset if the day comes that I don't need to be removing lymph nodes. So I like this to end my talk. As we, know, everything changes when you have a diagnosis of cancer. Breast cancer is no different. It changes who our patients are. But I think as, the group that treats breast cancer patients, our goal really needs to try to create a situation where the new normal is as close to the old normal as possible. We have a long way to go, but with all the research going on, we're getting closer and closer. So I thank you very much for your attention, and I'm happy to answer questions.
Wow. Thank you for that great talk. So fascinating. The history, and then the new technology and the new studies, really terrific. I'm so happy for the patients and for you. So we do have some questions coming in. And just as a reminder to the audience that we invite you to type your questions into the Q&A box, and Dr. Mason will address as many as we have time for. So the first question, how long between MAG trace and the receipt of the results?
So I assume you mean the results from the breast procedure. So with a mastectomy, it typically 1 to 2 weeks is what we're looking at. It's a lot of tissue for the lab to go through. And again, since they're looking for any evidence of breakout, they have to be very, very careful. But, the MAG trace, theoretically is there 30 days, maybe a little bit longer. But if I have a patient who the report comes back and says invasive cancer, I am getting them into the OR right away. I do not want to lose the opportunity that the MAG trace has given me. So it's expedited.
Oh, excellent. Thank you. The next question, what question should a patient ask about their lymph nodes when diagnosed with breast cancer?
I think that's a good question. I mean, I think does the imaging that they've had, because when people are diagnosed, it's through mammogram, ultrasound, or some sort of imaging, show any evidence of abnormal lymph nodes? Does the physician feel any abnormal lymph nodes? If a biopsy's been done, what do the results mean? And definitely if the lymph node had cancer in it, trying to get a good understanding of what lies ahead and what the options are. We really in this day and age try to tailor the treatment to the individual patient. And sometimes that's, I'll hear from patients, well, I know someone and this is what they had. Why is my treatment plan different? And that's because we're tailoring it to the patient, their health, their medical issues, their cancer, and basing it all on the research that's been done.
Excellent. The next question, what is recovery from microsurgery like, and are there any risks?
So in terms of risks, there are risks inherent in any operation, which is, bleeding and infection, wound healing. It's no different. It's no different whether you have the lymphatic bypass or not. It's a longer operation depending upon how many reconnections the microsurgeon makes. And so the longer an operation is, it does lengthen your recovery. The time under anesthesia is a stress. This is being done to prevent lymphedema. So, there is benefit to it, but they're really the numbness that some people have after a node dissection is because of the node dissection. It's not done because of the bypass procedure. So really, there's not a lot of additional risk related to it.
Very good. It's terrific that we have that available here at Baystate Health. The next question, can you explain in situ again, please?
Yes. So you think of the duct like a tube straw. There's cells lining the duct. Those cells, the word carcinoma means that those cells are growing uncontrolled. In situ means that they're still trapped within the wall of the duct. So by definition, if they're trapped by the wall of the duct, they can't go anywhere. When there's breakout through the wall of the duct, that's what we call invasive cancer. So how we manage the breast is no different whether you have invasive cancer or in situ cancer. What's really different is whether lymph nodes need to be removed or not.
Oh, that's very clear. Thank you. The next question, what exercises are recommended for a patient who had a couple of lymph nodes removed?
Any weight-bearing exercise is recommended. Actually, use of the arm is recommended. Not using it is actually the worst thing you can do, and can predispose to lymphedema. So being active, reaching, you can put your arm up over your head. Sometimes it feels tight after you've had lymph node surgery and if you had radiation, but you're not going to hurt anything by moving it, and it's only going to benefit you. I like having my patients get light weights. 2 to 3 pounds is fine, and put it into their daily regimen of just, bicep and tricep curls. Anything causing muscles to tighten will help form new lymphatic pathways.
Oh, terrific. The next question, is the microsurgeon on hand for all breast surgeries, non-lymphodectomy? Is the microsurgeon on hand for all breast surgeries? It seems like including non-lumpectomies.
No, so the microsurgeon is specific. It's a specific coordination of care for the lymphatic bypass. I hope I answered your question correctly.
Yeah, that's what they specifically do, okay. And they're on board for it. Yep, terrific.
Yep.
I don't see any more questions, so we'll give the audience another minute or two to chime in if they have a question, but I think those are really great ones. And I really appreciate the talk and the way that you're staying so up to date with everything for breast cancer patients. Yeah. It's truly terrific.
It's definitely a rapidly evolving field. You want your care team, to be attending all those national conferences and be practicing based on the evidence and follow national guidelines. It's so very important. And as I said, if I give this talk next year, there's probably going to be another couple of slides with new data. And I'm hoping that it's all, again, that de-escalation of care as our other treatments get more effective.
Terrific. Oh, it looks like there's one more question in the queue. Is there a roadmap for care that you provide patients?
So when I meet with a patient, and this is what we breast surgeons do, we need to understand all the pieces, the medication pieces, the radiation piece. So I just don't talk to them about surgery. I actually talk to them about, your cancer does use the hormones, so you will get an anti-hormone pill. If I know they're going to need chemotherapy, I prepare that for them. I talk about it. I talk to them about the expectations of radiation so that if they're deciding on a lumpectomy and that means they need radiation, that's an educated and informed decision. You know, we're typically, the surgeons are the first person that a patient sees when they're diagnosed with breast cancer. And if we can't talk about all the pieces that go into breast cancer treatment, I think it's really, you know, hard for a patient to know what they do want. And ultimately, this is a world of shared decision making. So, you know, patients need information so they can decide what feels the best for them as the right plan. So yes, I do provide a roadmap. We have all this written material they go home with. Oftentimes I have other conversations with the patient as they go home and try to digest that roadmap. We try to go over it again to make sure that it's all as clear as possible.
Well, thank you for your expertise. We thank the audience for attending. And Dr. Mason, thank you for staying on top of all this great new research and procedures. And hopefully we can get you back with any updates, possibly next year for Breast Cancer Awareness Month.
All right. Well, thank you for having me. It's been a pleasure.